Hey guys, welcome back to my channel Harrison Learns. Today our topic is chronic obstructive pulmonary disease. Let's dive into that. What is COPD? COPD is defined by chronic airflow obstruction, meaning air gets stuck in your lungs, making exhalation a struggle. There are like key components like emphysema and chronic bronchitis, where emphysema is defined by destruction of lung alveoli, leading to enlarged air spaces and less surface area for oxygen. And whereas chronic bronchitis is defined as chronic cough and phlegm, excessive phlegm production means it is caused by persistent inflammation. Okay, it is caused by persistent inflammation. It also includes small airway disease. Next, we are going to learn about risk factors. What are the risk factors for COPD? One is major risk factor, that is cigarette smoking. It is a major risk factor. Okay, it's a major culprit in 80 to 90% of cases. And next one is airway responsiveness. Like your airway becomes super hyperactive, overlapping with asthma. But what is the major difference between asthma and COPD? In asthma, basically, airway hyperresponsiveness is episodic. It is episodic and more reversible, okay? More reversible. But whereas in COPD, it is constant and it worsens over time and it is irreversible. And there are like occupational exposures like dust, fumes, chemicals, other factors like pollution or genetics play a role too. We will learn about that later.
Now, let's dive deep into the pathogenesis of COPD. Basically, how it starts. It starts with exposure to cigarette smoking and genetic susceptibility. In this, there will be deficiency of alpha 1 antitrypsin. Okay, alpha 1 antitrypsin. I will tell you about this later. Okay, now this exposure to cigarette smoking will activates inflammatory cells in lungs. Okay, inflammatory cells in lungs like macrophages, neutrophils, and T lymphocytes. What will this do basically? These release proteases. Okay, these release proteases like too much proteases like MMPs, neutrophil elastases. Okay, so I told you right about alpha 1 antitrypsin. Basically, this alpha 1 antitrypsin, okay, this alpha 1 antitrypsin, it will keep in check of this proteases. But in this thing, there is like too many proteases and not enough antiproteases. That's the reason these leads to extracellular matrix destruction. This is classic proteinase and antiprotease hypothesis. And this damage leads to structural cell death where alveolar wall breaks down and airway scar. And when repair goes wrong, instead of fixing, the lung form disordered scar tissue and lose elasticity. Because of all of this thing, your small airways become narrowed, okay, and mucus and fibrosis and extensive small airway destruction will be present. Basically, this is nothing but airflow obstruction, which is hallmark of COPD. Now we will learn about pathogenesis emphysema. It is same as I discussed before. First is chronic exposure to smoking that leads to release of inflammatory cells that release proteinase and that damage extracellular matrix, and that leads to structural cell death that leads to disordered repair of elastin. What because of this in emphysema there will be destruction of gas exchanging spaces that leads to large emphysematous air spaces. There are three types of emphysema. One is centrilobular, one is panlobular, and another one is paraseptal. In centrilobular, basically it is mostly associated with smoking, okay, and they are more prominent in upper lobes. But whereas in panlobular, they occur most commonly across acinar units of lungs, and these occur due to alpha 1 antitrypsin deficiency, and they are more common in lower lobes. In paraseptal, they occur along pleural margin with relative sparing of lung core. It happens due to airway inflammation. Okay. In emphysema, patients are thin and non-cyanotic at rest. Okay, patients are thin and non-cyanotic rest. That's the reason they are called as pink puffers. Okay, what it means, like it is not, there is normal oxygen at rest, and they have prominent use of accessory muscle. And whereas in chronic bronchitis it is called as blue bloaters. Why it is called as blue bloaters? Because it is cyanotic. Okay, it is cyanotic matlab low oxygen, and patients have blue tinged skin, and patients are heavy, like overweight also. Now we'll discuss about pathophysiology, which is nothing but functional consequences. We already discussed COPD core is airflow obstruction, right? Because of this, there will be persistent reduction in forced expiratory flow rates, which is classic definition of COPD. Okay, and there will be air trapping. Because of this, small airways collapse during exhalation, trapping air in alveoli, and this leads to hyperinflation of lungs. This hyperinflation of lungs will increase your total lung capacity of your lungs, and will it also increases residual volume. Okay, and this flattens the diaphragm. This flattens the diaphragm, making breathing inefficient. Because of this, elastic recoil pressure increases, because destroyed elastin can't snap the lungs back, and that causes airways enlarge. And there is another thing called as gas exchange. Okay, gas exchange abnormalities. In this, there will be non-uniform ventilation, like some areas get too much air and others too little, which leads to ventilation perfusion mismatch. Like well ventilated areas have low blood flow, and poorly ventilated areas have high flow. This causes hypoxemia and sometimes hypercapnia also, and this is characteristic of COPD. As I already discussed about genetic considerations like alpha 1 antitrypsin deficiency, because of this there will be lot of proteases, and because of this there will be damage of extracellular matrix. And now let's dive into diagnosis. First we have check history. In history, there will be dyspnea, cough, sputum production, and one more important thing not to forget is smoking history, because smoking is major risk factor for COPD. And what is a gold standard for COPD? Obviously, it is spirometry. When you do spirometry, there will be decreased FEV1 to FVC ratio, which is less than 70%. Same as asthma, but the major difference is when you give bronchodilator, there will be minimal reversibility, that is less than 12% decrease in FEV, but there will be maximum reversibility in asthma. That's a major difference. You can also do radiological studies for classification of COPD. First, you can do chest X-ray that shows overinflation of lungs. If it shows bulle, paucity of parenchyma or hyperlucency, it suggests emphysema. You can do CT scan. Okay, like for more for more detailed classification. Uh, this is very important. This table is very important. This is taken from Harrison. This is gold criteria for severity of airflow obstruction in COPD. Okay, first stage, it is mild stage. In this there will be reduction of FEV1 to FVC ratio, that is less than 0.7, but FEV1 will be greater than or equal to 80% predicted. And in second stage, which is moderate stage, in this FEV1 by FVC is less than 0.7, and FEV1 is greater than or equal to 50% but less than 80% predicted. And in third stage, which is severe, there will be same as second and first stage, but FEV1 will be greater than or equal to 30% but less than 50% predicted. In fourth stage, which is very severe, there will be FEV1 by FVC less than 0.7, same as like last three stages, and but FEV1 is less than 30% predicted. Remember this table, it is very important. Now let's discuss about management of COPD. First, we'll go through non-pharmacological treatment. The first primary intervention is smoking cessation, as smoking is major risk factor to develop COPD. You can do pulmonary rehabilitation, in which structured program with exercise, education and nutrition, and they reduce dyspnea and boost exercise tolerance also. And you can give vaccination like pneumococcal to prevent infection which trigger flares, and you can give oxygen therapy who has chronic hypoxemia. And Now we'll discuss about pharmacological treatment. First preferred treatment is obviously bronchodilators. It is preferred in inhaled route, and I already discussed about how bronchodilators work in asthma. Once go and check that video once again. And first, short acting muscarinic antagonist or long acting muscarinic antagonist like ipratropium, tiotropium respectively, they are primarily preferred. And short acting beta agonist or long acting beta agonist are also preferred. Like short acting beta agonist is preferred for mild COPD. Inhaled muscarinic antagonists are more effective for moderate to severe COPD like LAMA, like tiotropium, than short acting beta agonist or long acting beta agonist. You can also give inhaled corticosteroids. They are mainstay to reduce exacerbations. You can give alpha 1 AT augmentation therapy when the serum level of alpha 1 AT is less than 11 μm. And now let's go, once we'll go through this table which is taken from Harrison. So this table is taken from Harrison. How do you the initial pharmacological treatment for COPD? I already told that SABA is given for mild COPD, right? If the patient have 0 or 1 moderate exacerbation that doesn't lead to hospital admission, then there is like two groups, group A and group B. Okay, it depends on score what to give. For group A you can give a bronchodilator. For group B you can give a long acting bronchodilator like LABA or LAMA. And if the patient have greater than or equal to 2 moderate exacerbation or greater than or equal to 1 leading to hospitalization, and the score is like this. For group C you are going to give long acting muscarinic antagonist. For group D you are going to give combination therapy. Okay, LAMA plus LABA or ICS plus LABA or LAMA single. Okay, consider if this LAMA plus LABA is considered if patient is highly symptomatic. And if this inhaled corticosteroid I already discussed, it is given if patient has eosinophil count greater than or equal to 300. Okay, for exacerbations of COPD, exacerbations is nothing but acute worsening of respiratory symptoms. For mild to moderate exacerbations, you can give short acting beta agonist or antibiotic if infection suspected. For severe, you can hospitalize a patient. You can give non-invasive ventilation for respiratory failure patient. And there are some advanced interventions like surgical interventions like lung volume reduction surgery. It is used for severe emphysema patients. Okay, severe emphysema patient, basically it removes damaged tissue and improve your lung function. If there is bulle, you can do bullectomy. Lung transplant, it's for obviously end stage patients. That's all. Thank you so much. If you like the video, subscribe, share and comment down if you have any doubts. Thank you. Goodbye.